Okay. Hi, my name is Busmah, and I'm going to be giving a presentation on demyelinating syndromes, particularly multiple sclerosis. So let's start. So I chose this topic because as a third-year medical student, I was given the responsibility of charting the vital signs of a patient who came in who was a 40-year-old male, and his presenting illness was blurred vision. And he had the past medical history of right upper arm weakness that resolved on its own. And he didn't even take any medical consultation for it. And in this patient's physical examination, from what I remember, it was a central field defect, visual field defect, and pain upon eye movement, which was already like a buzzword for multiple sclerosis. And I thought I had it down. I was like, okay, I'm just going to impress my attending and say it's MS. And when I read the diagnosis, it says suspected MS pending radiology report. So I kind of asked my attending and asked him like, oh, but if we can do a spinal tap and we can find the illegal banding, wouldn't that be enough to diagnose MS? And he said, no, it's one of the few conditions where it's solely responsible, radiology is solely responsible for the diagnosis. So I thought it was a really cool topic that we could discuss. So let's begin that. Beginning with the pathology of multiple sclerosis, usually people think that multiple sclerosis is an autoimmune disease that attacks the myelinating cells of the central nervous system, which is absolutely true, but the complexity of that autoimmune pathology has recently been linked to a chronic vascular condition. So this image right here is an image of the vein. This is a pathological slide, and right here you can see the boundaries of a collapsed vein, and around that you can see all these basophilic nuclei, which are lymphocytic infiltrates that represent an autoimmune reaction to these venules. So that's why they kind of think that these infiltrates then later on also affect the myelin sheaths and present with all the multiple sclerosis classical symptoms of neurological symptoms is disseminated in space and time. So usually when a patient comes in with a neurological condition, we think instantly of getting a CT scan done. And we do that to rule out generalized neurological conditions that are more common, such as any vascular defects, strokes, and the like. But a CT in this case is not the preferred modality. In fact, it doesn't really show much. Findings that we can see for MS in a CT scan are plaques that are homogeneously hypoattenuating, which means they're appearing a little black, which on a CT, if it's a poor quality CT, you already see granulations within the image, so it doesn't really help us much. And then brain atrophy, which is a non-specific finding in MS, and we have some plaques showing in contrast enhancement in the active phase. So a lot of patients get caught on CD on the active phase, but again, you need an MRI to confirm the diagnosis. Moving on. This is a good comparison of an MS case showing what you can see in a CT versus what you can see in an MRI. So here's the CT scan. You can't really see much in here. None of the lesions are enhancing. Those hypodense lesions that it mentioned on the CT scan, we see that right here, and a mirror image of that on the MRI over here. So it's not really specific, and you wouldn't particularly scream that this is multiple sclerosis when you see it. So we'll go into details on how to diagnose an MS from an MRI in just a little bit. Before we get into the diagnosis, I wanted to briefly explain what T1 weighted, T2 weighted, and FLAIR MRIs were, because the criteria for diagnosis of MS really particularly states which MRI and in which conditions we would say that it is multiple sclerosis. So there's a T1 weighted and T2 and FLAIR MRI. Understanding of which we'll have to understand the basic principles of how MRI works. I'm briefly going to touch on that. I'm sure you guys already know. But so it basically works on the magnetic resonance of protons within a molecule of water. So what it does is the machine sends out a frequency, a radio frequency, which then aligns all these protons, which have their own specific alignment in the tissue, and makes them all regular in their alignment. So T1 weighted images kind of see the time it takes for these protons to get aligned into one alignment, and that's T1 weighted. And T2 is a measurement of how these protons then reverse back into their original alignment, meaning they go back to what they were before they were getting hit by that radio frequency. And then flare is pretty much T2 weighted, but it's because the exposure is greater. And I'll explain that by using these terminologies TR and TE, which are used to describe the time of repetition of the radio frequency. So for each slice, the radio frequency on an image is exposed multiple times. So for a T1 weighted, there are multiple slices going, there are multiple exposures to radio frequency. So it's a shorter TR. And then for TE, it means time to echo, which is when that de-alignment of protons that I mentioned before comes into play. So echo would be that radio frequency that comes in. So the T1 has a short echo TE time, because we don't really want to see when those protons are getting de-aligned. We want to see when they're getting aligned. Whereas in T2, when we said that we want to see how they're getting de-aligned, both the TR and the TE are longer. And in flare, like I mentioned, that it's closer to T2 in the mechanism, it's that the TR and TE are even much more longer than in T2 weighted. So we can clearly see over here that these TR and TE components increase the enhancement and the contrast in these images. So if you look at T1, you can't see a clear delineation between the white matter right here on the periphery and the gray matter. You can't really see much of that. And the ventricles and the CSF are all black. But over here, we can see a clear line delineating the white matter. And then we can see over here that there's a gray matter. The ventricles are all white. And over here, again, in the flare, we see a really nice contrast between the white matter and the gray matter. And this is one of the reasons why flares are really good at picking up pathology. So, moving on. We're going to talk a little bit about the slices that we can see, or the planes of the images that we can see for an MRI. This would be the transverse, the axial, or the horizontal image of a brain, where we can observe all the facets and parts of the lateral ventricle. Right here, we can appreciate the frontal lobe, parts of the parietal lobe, and the occipital lobe right here. Sagittal section, which is a vertical section. We can see the frontal lobe right here. We have the lateral ventricle, we have the corpus callosum, we have the fourth ventricle, and we have these infratentorial structures, which will include the cerebellum and the pons and the medulla. This is important to know these structures, because these are the ones that we will be focusing on when seeing MS lesions. They're usually periventricular, they are juxtacortical, and they're usually infratentorial in nature as well. Again, we have a coronal section that we can see over here. And we have the lateral ventricles. We can see parts of the thalamus and areas over here that are also the caudate and lentiform. Right. So, and this is the temporal lobe right here that we couldn't appreciate in the other views. Moving on. So this is the Mcdonald's criteria. It's the criteria that's used to diagnose multiple sclerosis. So you can see dissemination in space and dissemination in time, which means that a lesion can present in one area, or it can present in an area over a period of time, meaning it can be present at one moment and then it can show up the next moment. And these can be separated by months or even years. So over here, we see the criteria for dissemination in space, where it says a T2 lesion, one of them or more in at least two of the MS typical CNS regions, which is periventricular, juxtacortical, infratentorial, and the spinal cord. We will go into all those in the following slide. So we can see dissemination in time where it says it's simultaneously asymptomatic, contrast enhancing, and non-enhancing lesions at any time. So that means that in one given image, you can have both an enhancing and a non-enhancing lesion present. And that's kind of characteristic for MS, and that ties into pathology, which shows that there are lesions where there can be chronic inflammation, and that will be the non-enhancing lesions. And then you will have lesions that will be enhancing, where active inflammation is taking place and there's the active lesion going on. And then there's an other criteria for it. So it can be either a new T2 or a contrast enhancing lesion on a follow-up. And then there's the second clinical attack, you wait for that. So over here, it mentions contrast enhancing. So you can use a T1 with a contrast to view these lesions as well. So that's what it means when it says, or contrast enhancing lesion. So this is a nice image where you can see all the typical image features of multiple sclerosis. So we have the lateral ventricles right here, and we have these lesions that are hyper intense right here. And then we have the juxtacortical lesions right here, which are the U fingers. It's juxtacortical because it's not within the cortex. It's like right there, barely touching the cortex. And then we have the infratentorial aspects of it in the following images. But we can also see that these juxtacortical lesions usually are enhanced in the temporal lobe of the brain. So this little yellow arrow here is also being pointed out as an enhancing lesion. It's mentioned over here because these are quite common to find as age-related or vascular-related changes. And it's one of the reasons why the Mcdonald's criteria was created, because not all enhancing lesions point towards MS. There are particular areas which have, in studies shown that they're more correlated with MS. So these lesions, subcortical lesions, are usually not associated with MS. So over here, you can see a zoomed image of the juxtacortical lesions, where you can see the U shape right here, and that it's within the white matter and it's not within the gray matter. Conversely, you can see the difference over here, which is actually a vascular pathology. You can see this gray band that comes through right here, which differentiates it from a white matter enhancing lesion that is particularly seen in MS. I don't think that you can appreciate it all that much, but if you zoom in on the image, you would probably be able to see there's this gray band that's coming over here, which kind of shows that there's involvement of the gray matter as well as the white matter, which is not the pathology of MS, as we know that it's a white matter lesion. So only the white matter gets enhanced over here. Moving on, we can appreciate periventricular lesions over here near the lateral ventricles. Right here, they're all hyper intense. And we have these ovoid lesions that are very classic of MS. They're called Dawson Fingers. And these are where the pathology of the chronic venular inflammation ties in, because these are venules that are running perpendicular to the lateral ventricles. And when they are inflamed, they can rupture and they can cause these Dawson fingers that enhance an ovoid shape. So infratentorial aspect means that it's going to involve the areas that are infratentorial, that is below the tentorium cerebri, and that would be the cerebellum right here. You can see that, and we have these hyperintense lesions over here and over here. And then we have areas that are like the pons and the medulla that can also enhance, and we can see that, some of them in the pontine lesions over here, and over here, hyperintense lesions here. Moving along, we also have spinal lesions that can show up in multiple sclerosis. This is I think this is a proton density weighted image. It's pretty much similar to an MRI, but over here it focuses more on the protons in water, I believe, and that's how these images are more enhanced. I'm not exactly sure about the entire details of the mechanism. I tried to read up on it, but here we can see these hyperintense lesions within the spinal cord. So one of the classical features of these lesions are that they're usually either 2 vertebral segments larger or less than that. They're not usually larger than that. And they're present in numerous numbers, like there's multiple lesions are present in the spinal cord. So here we can see a zoomed image of those lesions that are hyperintense. And you can see that they're pretty much small compared to the vertebral bodies. So here is an image showing a person who initially came in with the suspected diagnosis of multiple sclerosis, and we can see one of his hyperintense lesions over here. And conversely, we can see his repeat MRI from when he came 3 months later, and we see new lesions have been, have occurred. So you can diagnose multiple sclerosis based on that. Next, we can go into the variants and the differentials of multiple sclerosis, because there are many diseases that can mimic multiple sclerosis, not only clinically, but also on images as well, or they share certain features on images. So it would be a good way to decipher whether it truly is MS or not. So this is a long list of differential diagnoses for multiple sclerosis. So as mentioned, vascular pathologies can result in clinically mimicking symptoms of MS. And we can even see that in images as well, where we can see subcortical hyperintense lesions that can be periventricular as well. So we have inflammatory diseases where vasculitis can come in, where SLE, Beckett's, Sjogren's, and sarcoid can also be present. And we have inflammatory bowel disease, which can also be a diagnosis. And then we have infectious elements that can show up on imaging that can mimic multiple sclerosis in clinical settings as well. Metabolic, traumatic, and hereditary conditions are also something that we can see as multiple sclerosis. So one of the multiple sclerosis variants, which is very rare, is the tumefactive multiple sclerosis, and it presents in the elderly population, and it can mimic the same clinical symptoms and presentation as that of space-occupying lesions and infections. And you can see here that a large area of the nervous system is involved over here in the occipitoparietal area. And they make these rings that are very classic for tumefactive multiple sclerosis. But the catch over here is that these rings are incomplete. So say if this was a tumor, or if it was an infection, these are usually ring enhancing, and these rings are complete. But over here, you can see these rings are incomplete. You can appreciate that very well over here. It's one of the reasons why you would think that it's typically confused between a space-occupying lesion and a tumefactive multiple sclerosis, which is why they often take a biopsy of such complaints. And over here, you can see this is where the biopsy site was. So they use pathology to differentiate and make a conclusive diagnosis. Another variation that we have is Bellow's concentric sclerosis. And again, it presents with headache, neurological dysfunction, and it can mimic that of symptoms of space-occupying lesions. So the classic image finding for this is these world appearances, these world hyperintense areas in the image. Next, we have a very important diagnosis for multiple sclerosis, which is neuromyelitis optica. And it's important because multiple sclerosis patients can also present with ocular symptoms. So over here, we can see in this axial section, the left orbit is this entire orbit, and this is centrally present, the optic nerve, and it's hyperintense, showing inflammation. This type of a lesion usually presents with a lot of spinal lesions as well. So this is what we can perceive in a spinal image over here. You can see versus MS, this hyperintense lesion is quite large compared to what we said that it would be MS with multiple small lesions. So that's neuromyelitis optica. And another differential we can have is acute disseminated encephalomyelitis, which usually happens in children following either a viral infection or a vaccination. It's usually monophasic, which means we have one insult and one demyelinating incidence, as opposed to MS, where there is a multiple demyelinating insult. So it's multiphasic as opposed to monophasic in ADAM. So in imaging, these lesions usually come as bilateral hyperintense lesions that can also have periventricular involvement seen over here and over here, but classically this condition usually affects the thalamus and the basal ganglia area. So that's how you can differentiate them on imaging, because we also don't have any of the other criteria for the Mcdonald criteria being met, that is juxtacortical lesions. So that you can't see any of those enhancements over here. So you'd be more likely to suspect that this is ADAM as opposed to multiple sclerosis. Especially over here, because there's gray matter involvement, you won't think that it's multiple sclerosis. So this is another view of the multiple diseases that can mimic multiple sclerosis, but then you get imaging done and you can decipher that, okay, it's not multiple sclerosis. Over here, we have tuberculomas, which are disseminated all involving both of the hemispheres. And you can see that they're also hyper-intense lesions, but they don't follow the pattern described by the Mcdonald's criteria, as we had discussed. Over here, we see border zone infarct. So this is probably a patient who had hypotension. And you can see these watershed areas where the arteries kind of communicate with other arteries and anastomos there, where you can see most of the infarctions have taken place. We can see metastasis over here, which is a great way to decipher MS from tumefactive, as we had talked about. You can see that these lesions over here are complete rings, as opposed to that we had seen in tumefactive. Let's just go back to tumefactive for just a second. So over here, you can see that they're not complete rings, and they're usually isolated in one area of the brain. Whereas in here, we can see that they're complete rings, and because it's metastatic and not primary brain tumor, it's occupying multiple areas within the brain. Another infectious agent that can mimic MS is Lyme's disease. And you can see over here, there's multiple enhancing areas right here, which again do not fit the Mcdonald's criteria. And that's MS, it's Adams, and we have sarcoid. So you can't really appreciate in this image, but it's over here, you see like a hyperintense lesion that's going to show that it's inflammation right there. And then you have lymphomas that are space occupying lesions. So again, they're giant enhancing lesions right here. Okay, so this is another image that you would commonly come across and think, okay, maybe it could be multiple sclerosis. If you're someone like me who's a complete novice at reading radiographs, you're gonna think like, oh, look, hyperintense lesions around the ventricles, this is multiple sclerosis. But in fact, this image is a normal aging image. This is just an elderly patient who has probably some vascular comorbidities. So these areas are hyperintense because of vascular insult as opposed to multiple sclerosis. Moving on, there's a feature that you always come across, which is a clinical radiological paradox, which means a patient might be showing no symptoms at all, but radiologically, you would see that they have multiple sclerosis. So that's a paradox you have to keep in mind. At that time, it's the clinician's responsibility to see whether you want to wait on this patient's further workup to see like whether this patient really has multiple sclerosis and whether you want to start them on an intervention, on like pharmaceutical intervention or not. But till then, there can be a clinical radiological paradox where it shows a pathology is present, but clinically it's not presenting, or it shows a really severe condition is present, but the patient does not show that clinically through symptomatology. And in conclusion, multiple sclerosis and demyelinating diseases require radiological consults to be a confirmed diagnosis. And well, hopefully this presentation will help us novices be able to understand radiology a little better when it comes to demyelinating diseases. Thank you.